Hello, it's Shelly with Shelly's Nursery Review, and we're back. Now, one of the things I tell you is when we start talking about this patient with rescue, we talked about medications, but now we have to move on because if this patient's SVT is like disrupting their life, then they're going to need to be scheduled for a maintenance procedure called a catheter ablation. But first, let's just recap a few things. We already talked about the fact that SVTs is very different from sinus tachycardia. We said that by definition, SVTs has to be a heart rate greater than 150. We also said that tachycardia, on the other hand, is a heart rate between 100 and 150. We wanted to make sure we remembered that there may be apparently no P waves, but that's just because the rate is so fast that the P and the T look like they're one. So you may not see that predictable half moon shape that the P wave right before the QRS would give you. In this patient, you may see it look like one big mountain between the spikes. Now, we talked about counting our QRSs, or not our QRSs, but remember, we talked about counting our Rs. We talked about even getting a history from the patient. Did this happen all of a sudden? Were they just chilling like a villain and nothing was going on? Or was this patient typically having some symptoms consistent with tachycardia? You know, like a fever, like a pulse ox less than 90, like were they hypovolemic and post-op, lost a lot of blood? Were they dehydrated? Is their BUN elevated? Or was this patient pregnant? Because SVTs are very common in pregnancy. So we kind of really need to get a good history. And then of course we just need to figure out, what are you doing right now, patient? Like, what do you feel? How do you feel? What about those vitals? How's that pulse ox? What's going on, right? Because you know we don't put on oxygen unless we truly have an abnormal pulse ox. Now, so if we come over here, this catheter ablation is considered maintenance. It is a same-day surgery, outpatient for some. We're gonna start the IV after we make sure this patient is appropriate. We've checked the consent form, made sure it was signed. We made sure they were NPO after midnight and they didn't have a cigarette in the car. Then we're gonna go ahead and start that IV with an 18 gauge angiocath. We're gonna go ahead and prepare to give our patient IV push Versed. Sometimes you're taking a test that is all generic drugs. That would be NCLEX. Maybe not in school, but on the NCLEX, it's all generic meds. So Versed is midazolam. It is a benzodiazepine medication. You should be using the same color marker for all meds. So this medication should be in the same color that adenosine was in. All meds should be one color to keep your life consistent with medications. This benzodiazepine has a sedative quality, and it has an antidote, because if you get too much benzodiazepines, you can pretty much crash, right? It's sedating. So with this medication, the antidote is flumazenil. Some people get confused. They think Narcan. No, this is not an opioid. The antidote is flumazenil. Something else I want to say before I go to the next phase of this lecture is that with this benzodiazepine, you had to remember conscious sedation means the patient can still respond to my commands and they are awake. They just are not anxious and they're not really feeling a whole lot. And also the most important one is this drug, this medication, midazolam, and remember benzodiazepines end in lam or pam. This midazolam is also an amnesiac. So the patient will not remember what exactly happened during this procedure. So we'll come back to the last phase of this lecture.